Thank you, Ziad. Hi again, we met in Bombay. And thank you, IPCI, to have me here. And they've given me 10 minutes to give you evidence on OCT. So I'll try to include the important ones. So one of this study was the eye-optico study, where they did a real-time optical coherence tomography and angiocore registration, whether what effect it has on decision-making during PCI. This was the aim to find the impact of real-time OCT and ACR and what does difference it makes to decision-making for PCI optimization in South Asia. The primary objective we know is that pre-PCI, what strategy changes would happen, and after you do the PCI, what strategy changes would happen. And the secondary objectives were very important, whether it is success of the procedure, MACE at 6 months and 1 year, and we are always worried about the contrast load and the additional time you take. So this was the study flow. We won't go into details. So angio, OCT, ACR, PCI, post-OCT, and whether we have strategy change. And all the images were analyzed by a core lab. So there were 500 patients enrolled, and eventually 472 patients were included in analysis. And then 2 patients died cardiac death after 3.5 months of PCI. Follow-up at 6 months is 443, a follow-up at 12 months is 241. And the variables analyzed are the demographics, indications, vessels, treatment, lesion preparation. Inclusion criteria and excluding, we can go out. We don't need this now. The baseline characteristic, as you see, mainly were hypertensive, diabetics as expected, some amount of renal dysfunction. Predominant lesion treated is the LAD, which is most of the cases, followed by the RCI. RCI on the left main was about 5%. And this was the pre-PCI strategy change which happened from angiography to OCT. As you can see, the lesion preparation, the stent length, and the overall strategy changed in more than 70% of patients. And from OCT to ACR, the changes were only 22%, because then the angiocore registration generally helps in lesion length and preparation better. And of course, post-PCI strategy change was overall 30%. So the addition of ACR with OCT did not have an additional strategy change post-PCI, and the average change was 90%. As you can see here, the lesion preparation, the stent length, and the stent diameter, and of course the change in landing zone. That's very, very important, which we've discussed many times, because that's a harbinger of future predictive events, and if you miss the dissections. So the overall change comes about 90% of lesions. And the secondary endpoints, if you see, in the initial phases, the pre-procedure and post-procedure time, there's a difference about 3 to 4 minutes, and the assessment takes another 3-4 minutes extra. The total contrast is relatively higher in these earlier studies. The volume was 205 and the OCT was 40.5. But this has been obviated now when we start taking angio runs and the OCT runs at the same time. So we've stopped taking angio runs separately. So the conclusion was that OCT and ACR changed the decision making in 90% of lesions. Pre-procedure change was 70%. Angiocorrelation added another 22%. And post-procedure OCT changed the strategy by 30%. Then came the CLE OPCI study, which was done in 3 Italian centers with a high OCT volume, and matched randomization of 335 patients in the OCT plus angiography and 335 in the angiography with only. And the primary endpoint was 12-month rate of cardiac death or non-fatal MI. So what they found that the cardiac death, the death and MI was all significantly lower in the OCT plus angiographic group. And this was predominantly driven by the edge dissection, stent malapposition, and expansion of stents. And this was a definite direction that we can influence mortality to some extent, although this was not powered to say that yes, it is going to change the MACE rates in future, but gave us a direction. Then came the I'm talking a little bit of the Illumin OCT type. It's a very important study that has changed the way we think. And what changed in this pre-PCI to post-PCI, the stent length got longer or shorter depending on the OCT images. The post-PCI changes, the important thing we realized is malappositions and edge dissections were detected much easier, which did contribute to MACE. And we realized there was a 12% absolute reduction, the ARC in 1 year of myocardial infarction. So this clearly showed us that imaging helping us make better decisions and help patients reduction in MACE. The Illumin T was decided to demonstrate equal MSAs between stent, IVUS and OCT, and there was no significant difference between OCT and IVUS in terms of MSA. And the advantage OCT carried over IVUS at that time was that you could see more MACE-related outcomes, which like malopposition and dissections were seen better than IVUS. Illumin 3 background, we all know that PCIs is commonly guided by angiography alone, and IVUS guidance has shown to reduce major adverse cardiovascular events after PCI. OCT we know shows superior relation to IVUS. We get a better resolution, but data supporting improved or equivalent outcomes are lacking. So the hypothesis was that using this novel stent sizing protocol, whether OCT guided PCI will be non-inferior to IVUS guided PCI and superior to angiographic guided PCI in achieving acute post-PCI MSAs. So this was the protocol, randomized 1:1, stratified by site, equal distribution. The inclusion was single native vessel, one or more target lesion, reference vessels, lesion length less than 40, and of course usual exclusion criteria as we see in randomized trials. And this was the results summary. It was clearly superior to IVUS guided PCI in detecting certain predictors which we've been talking about, again the edge dissections and the maloppositions. The stent expansions was equivalent between IVUS and PCI, but of course it was significantly greater stent expansion as compared to angiography alone with greater procedural success. The future is the Illumin 4. We are waiting for this trial to give us more idea about the MACE and the benefits. The objective, as we know, the superiority of guided stent implantation strategy as compared to an angiography guided stent implantation. We need larger post-PCI lumen dimensions, and this should translate into better outcomes and reduce MACE events. And of course, after hospital discharge, all patients will have a clinical follow-up 30 days, 1 year and 2 years. So the primary data is still not published. So what is the takeaway from these slides and the data we have till now? The Illumin 2 was propensity matched in all comers. It told us OCT and IVUS resulted in comparable degree of stent expansion. Illumin 3 told us OCT achieved equal MSA and expansion to IVUS, but more frequently detects dissection, protrusion, and maloppositions. Illumin 1 told us that it leads to 90% change compared to pre-procedure in angiographic patients and reduce the ARC-defined MI compared to angiography alone. And CLEO-PCI clearly showed us significant death and cardiovascular end death at 12 months led to procedural change in 35% of patients. Thank you very much.